Personality traits. Now, we all have our personalities. You know, we all have a way of looking at things, feeling things, how we look at different aspects in life, right? So we all have an enduring pattern. Enduring means lasting, not very transient, but lasting patterns of perceiving, relating to, and thinking about the environment and oneself. So basically, you know, how we think, act, how we behave on a long-term basis, not in relation to one particular situation, right, is called our personality traits. Okay. And it is exhibited in a wide range of social and personal context. That means, like, almost all the time, everywhere, we exhibit our manner, our personality, style or manner, our features in our personality. So when it becomes a problem, when does our personality becomes a problem? Only when inflexible and maladaptive, and if these traits cause significant functional impairment or subjective distress, these personality traits constitute personality disorders. Are you clear? So personality traits we all have, and when they become a problem to self as well as others only, it becomes a disorder, right? Now, an enduring pattern, a lot of disturbances, I think, from the journal club room. Maybe I'll mute you guys. Everybody, I'm going to ask you to mute your microphone, right? Some people are very noisy, so please mute your microphones, right? Mute your microphones, everybody. People who enter, mute your microphones, right? Right? Otherwise, I can't go on. I can't spend time asking you to mute your microphones. Please mute your personal computer microphones, right? Thank you. Right. So, a personality disorder, I'm wrapping up with the textbook description: an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. Now I bring to this definition the culture. You know, in some cultures, you know, a man is expected to be a little, you know, boisterous, you know, dominating and making decisions and all that. We don't call that guy is having, oh my God, he's having a personality disorder. We don't do that, right? Because that's normal for that culture. When we call a personality disorder to a guy's manner, it has to be, there should be a marked deviation from the expectations of the guy's culture too. And as I said, it is pervasive. That means it stays the same across different situations, different times, different places. And those personality traits are very inflexible. And a personality disorder does not fall from the sky suddenly. Okay. Those features have been clear from an adolescence or early adulthood. So in Sinhala, there's a kiyamana, hadena gaha petten depetten dane. That means from a very early age, you can know what type of bugger this bugger is going to be, the key. So the features of a personality disorder has been a little evident from a very early years of life. And these personality disorder features are stable. Not that the personality disorder guy is like a saint or so good and so functional for like 1 year or 2 years in adult life, then he becomes, problematic in his relationships. No, it doesn't happen that way. It's like stable over time. And the most important thing in psychiatry, when we say something is a disorder, that means there's always a functional impairment, a distress. Okay? Now, why do we have to learn about personality or personality disorders of one of our patients? Because some personality disorders, they act as predispositions. For example, there is a personality disorder called anancastic personality disorder. They're very rigid, and I will go into little details, not much. So those guys are more prone to have depressive disorder. Okay? And personality disorders act as pathoplastic factors, that is symptom or presentation changing factors. Say a borderline personality disorder, a disordered individual may present with a depressive disorder in a different way to a person who's presenting with depression without, when that person is not having a borderline personality disorder or any other personality disorder, the presentation of that person's depression will be different. So it's like a personality disorder could be a bit of a game changer. When I say that, it's like the presentation or the symptoms and signs would be a little changed because of the personality disorder of that individual. And in relation to treatment, again, if I have to take the example of borderline personality disorder, guys, the treatment of a non-borderline PD individual versus borderline PD individual, it is very difficult to treat the depression of a borderline guy because of the added features, the complications borderline PD brings into the management. Okay, so in relation to treatment as a predisposition and the presenting, everything could be affected by the personality disorder. Okay, now in general, what I say, when I say personality disorder, that means the pattern is manifested in 2 or more of the following areas. The cognition, or in very simple language, the thoughts, the thinking, cognition, thoughts, the thinking. That is to say, the ways of perceiving and interpreting self, and interpreting other people and perceiving other people, and interpreting events and understanding other events. Those things could be the personality disorder pattern may be seen in the way of thinking, and also they'll be seen in the way of feeling, the affectivity, the range, intensity, lability, and appropriateness of emotional response, and also interpersonal functioning. The personality will be very evident in the way that guy is dealing with people in interpersonal relationships, and also impulse control. So, students, if you're going to diagnose a personality disorder, your patient should have at least 2 of these 4 areas affected. But most of the time, most of these areas are affected in PDs, personality disorders, right? I told you these 2 areas, we discussed that. And the pattern is stable. We told about that. And another very important thing is the features of a personality disorder cannot be explained by another mental disorder. So And it is also not attributable to any other reason, such as a physiological effects of a substance. Say, if a person is like being very nasty and aggressive because of alcohol or any other heroin or some other substance, then you don't go and label that guy to be having a personality disorder, because that is that substance related behavior only, right? And similarly, head injury people, brain damage people, their personalities may be really changing. For example, frontotemporal dementias, their personality is changed. We don't call it a personality disorder because it has happened later in life. It's not evident through the lifetime, and it's not the enduring pattern of the characteristics of the person. It's a late development. And also catastrophic experiences such as concentration camp trauma victims, soldiers in the front of war. I'm sure Jaffna students have lived through that experience even as children. Some of you ask your parents, when you experience, even the southerners, when you are experiencing these very conflicts, threats to life, bomb blast, etc., etc. Those are very catastrophic experiences. They also can lead to a change in personality, but those are not terming personality disorders. Okay. Now, in general, personality disorders are categorized into 3 clusters: cluster A, B, C. And there's a very simple way of understanding these 3 clusters. This is how I understood as a medical student and as a registrar in psychiatry. Cluster A guys are really a little different, in the sense they're not fun to be with. They're very mistrustful, and there's a little oddity around them. They may be a little extreme, eccentric, and in every batch, you have 1 or 2, at least 1, or even in contemporary faculty culture, you have 1 or 2 such guy, but they are not like, they may be having a little traits, because if it's a disorder, it's very difficult to function, right? Cluster B guys are like dramatic, emotional, extremely charged, and they can be very erratic, not eccentric but erratic. They may not make logical fair judgments in life, but they are very dramatic, and they want life happening, kind of, right? Very emotional. So cluster B guys. Cluster C's are they are like little frightened mice, by which me they are like very anxious, and they cling on to others, and always very anxious, and they depend on others. If you have a roommate with cluster C borderline personality disorder, you will find that guy a real Annie in the sense, like, I don't know what's the Tamil word, guys. Yeah, a bit of a pain in the where, cluster C. So if it is a disorder level, it's a bit difficult to function. However, we'll go into details then of these individuals a little bit, then you'll understand more. So these are some prevalence figures from world literature. Unfortunately, to my knowledge, we don't have epidemiological data for personality disordered individuals in Sri Lanka. But I'm in the process of, analyzing some qualitative analysis of borderline PDs in Sri Lankan culture group. So again, that's a qualitative analysis. We see many, many borderline PDs, antisocial PDs to a lesser degree, and anancaustic PDs we commonly see in our clinical practice. So not that we don't have them, but we don't have data. Maybe when some of you take up psychiatry one fine day, maybe you can join us in research. Yeah, who knows? It's not that uncommon. This is some international study data. In one study, an old one, about 15% of US adults have at least one personality disorder. So when I see some of these American guys go in the streets against COVID restrictions, my God, I wonder how narcissistic they could be. Right, just a joke. So how to assess personality disorder? We give you long cases of borderline personality disorders commonly at the final MBBS in all the medical faculties. Sorry. So 1 hour or 30 minutes with a patient is not enough to diagnose personality disorder, but at the exam setting, you may have to pick, which is very unfair by you all, but borderline PDs. When we assess, right, we usually we don't give borderline personality per se. We couple it with the depressive episode and all that, so the students are not disadvantaged. So we need to evaluate the individual's long-term patterns of functioning. And as I said, the patterns must be long-lasting. It cannot be an individual one-off incidence of a response to a specific situational stressor, but or it can't be due to any mental health disorder, okay, or substances. And we should assess the stability of these traits. One situation, this guy is very aggressive, but most of the other situations, he was not aggressive at all. He was taking it cool. And, then over time and across different situations, you get a better idea about the patient. Okay. Now, it is often necessary to conduct more than one interview and to space these over time. When you go to wards in clinical setting, first interview, you gather some of the personality disorder features, then you work with the guy, until you finish your appointment, just not at a massive level, depending on your time. Just see what happens, how this patient is behaving. One time, particularly antisocial PD, the girls, medical student girls, you will find them like really charming, and you will wonder, oh my God, this nice young man, why is he in this ward? He's perfectly okay, But then when you get into the details, particularly when you have supplementary information, collateral information from the people in the patient's life, you will realize, oh my God, he's so charming, but man, he's so nasty, in the sense like antisocial PD I'm talking about. Okay. And it is complicated, as characteristics that define a personality disorder may not be considered problematic by the individual. I mean, no antisocial PD would come and say, hey, doc, you know what? I'm such a bastard. I lose my cool. I hammer, I smash people's skulls against the walls, and I'm so guilty about it. They are not going to say that, right? It's usually the others who's at the receiving end is going to tell, this guy, although he's very charming appearing now, he's this guy. And in the second interview, don't be surprised if he suddenly gets up and pulls a very innocent patient walking in the wards just because he felt that guy didn't respect him enough or something. Okay, so it's traits are often egocentric in most of the PDs. So when assessing, it's very important to have, in the long case setting, you have to say, however, I need to get collateral information to make sure that he's having a personality disorder, because 30 minutes of the damn time you examiners have given us. It's not enough to assess a personality. Yeah, don't be that harsh, but you know what I'm talking about, right? Development and course usually become recognizable during early adolescence or early adult life, as I said. But interestingly, some PDs, notably antisocial and borderline, tend to become less evident or remit with age. In Sri Lankan Sinhalese culture, we have a saying, වයසට යද්දි කොටියාගේ දත් හැලිලා නිකන් බොහොම කොටියා වගේ දත් හැලිලා ලොම් හැලිච්ච දත් හැලිච්ච කොටියා වගේ. Now the fellow has become so mild. You know, ඉස්සර ගමේ චණ්ඩියා. You know, if I am to translate that, people, you know, with age, SPD guy, a patient, would not be that aggressive, would be mild, would be a bit tamed, if you know what I mean, right? Like an old tiger whose teeth has fallen and the fellow can't hunt for any praise anymore. Yeah, but unfortunately, some personality disorders can get even worse, and particularly these cluster A people. They can get more and more paranoid and more tolerable and more odd and eccentric that the families find it very difficult to live with time. The adult children would come and say, "Ane doctor, earlier also my dad was a bit suspicious and, you know, very litigative, you know, taking all the neighbors in the village to courts for the slightest thing. But it's worse now. He's intolerable now. Those features are worsened, you know, the cluster A guys usually. Even OCD guys with age can become a little bit more features wise, right? So what is the deal with children and adolescents? Anybody? Can we diagnose personality disorder in children? Yes, there are any students who are working with me at the moment. What do you think? Come on, people. Somebody? Or Jaffna? Anybody from Jaffna? What do you think, guys? Can you diagnose borderline personality disorder, which is commonly asked from students? Can you diagnose borderline personality disorder in children or people under 18? Yeah.
No.
Okay. Good.
Their prefrontal cortex is not developed under 18 years, so they won't be considered as a personality disorder. We can't diagnose.
Yeah, very good. It's not only about the prefrontal cortex, Putta. Their total personality. Yeah. All the brain areas, like there is a famous lecture of mine. It's not my findings, but I quote some of the great studies done. It's available on YouTube also. Under Rupawahini channel, those guys have come and got little video clips from all us lecturers in Pera some years ago. So there's a little program called Rata. In that, I talk about the adolescent's brain. The Pera students, you should have the Moodle link. You can share with your colleagues. I have no issue. Your friends, peers from Jaffna or any other faculty for that matter. So they are the adolescent brain, the prefrontal cortex, and some of the executive functions, prefrontal cortex and even the parietal cortex, some of the areas, they are not properly developed. Okay. So the personality is not fully developed in a person who's less than 18 years. Deal? So you usually do not go and diagnose. Sandun, breaking your noisy. Sandun, can you please mute your video, audio? So for some reason, I can't mute you guys. Otherwise, one click of a button, I can mute everybody. Thanks, Sandhu. Right. Okay, cool. So, oops. Right. So what I was talking about, yes, people less than 18 years, you better not go and diagnose personality disorder. However, take definitely antisocial PD, you must not, almost never diagnose less than 18 years. At your level, better not diagnose PDs less than 18 years. However, at consultant level, at MD level, at child and adolescent psychiatry level, we do go and diagnose borderline personalities in people less than 18 years if we are very sure of the characteristics, the symptoms, and the overall enduring patterns of the clinical features of that kid, right? So if you are very sure, it's all right bringing in that fact at the discussion. If you have done very good at the history and MSc and management level, you can bring in that fact at the discussion level in your long cases, guys. Because that student, if you know that, I would discuss with my consultant and MD plus, because I feel I would want to get more collateral information. And I so far from my 30 minutes examination, this girl meets up with all the criteria for borderline personality disorder. However, only the age is the hiccup. I would discuss with my consultant. I believe she will turn out to be a borderline personality. If you're very sure, go say that. If you're very sure, right? That'll be a very good discussion point. But in general, yes, better not say pre-morbid personality when you are given an adolescent. Say pre-morbid temperament, because as one of you said from Jaffna, their personality is not fully developed to 18. Simple as that, right? So culture-related diagnostic issues comes in diagnosing personality disorders. You mustn't judge about personality without taking into account the individual's background, right? In some cultures, say New Zealand Maoris, they expect their guys to be macho and going to war, and that warrior mentalities, they are still in that subculture. So you don't go and say, oh my God, he's so up, he's bloody narcissistic, or he's ASPD, antisocial PD, right? You have to give some allowances to the culture, right? We discussed about this in the definition as well. So if you don't know about a certain culture, get somebody who knows about that culture when you assess the patient. So, right, okay, cool. And gender-related diagnostic issues. Some of the PDs are commoner in particular sex. Now, antisocial is more common in males, and this cluster Bs, well, antisocial is also cluster B. The other guys in cluster B, borderline and histrionic, they are more common in females, and dependent personality disorders are also more common in females. So just because this is a very common pitfall, even not so experienced registrars also falls in psychiatry. Just because you see a very powerful dominant woman, you don't go and label her, oh my God, she is a personality disorder, this is a tough woman, is a difficult woman. Okay, so if you see a woman, a lady in a big position, taking big decisions, taking bold decisions, controlling a big client, workers, employees under her, say an executive at say Brandeis, the communist company these days. So, that woman has to be in that role. Or you need those personality characteristics to run an institute, right? Just because a woman is very dominant and powerful, you don't go and label, oh my God, she's a personality disorder. No, that's not fair. Because those are the social stereotypes about typical gender. Because a woman, Habana, has to be very mild and Landabolan and Sukumala and all that. No. Those are the social stereotypes. Well, the woman will be Landabolan, Sukumala in a situation where she's required to be so. Otherwise, if she's running a company, she has to bring out her leadership qualities and assertiveness and all the works, right? So don't overdiagnose, and of course, don't underdiagnose a personality disorder as well, just because of the gender, right? There are some guys who are like mild guys, they are not like, every guy is not macho, there are very mild, very sensitive guys. Then don't go and diagnose them as having a personality disorder, like the dependent or anything. They're just nice guys, yeah, right? So these are some of the breakdowns of the individual personality disorders, paranoid personality disorders. These are self-explanatory. I'm not going to go into details, right? They are suspicious, they don't trust people, they don't confide in others, sensitive to criticisms, are more, if you, offend them, man, they will be resentful for the rest of their lives. They are having sexual jealousy. Now, I have lived my life many years, unlike you guys. So whenever I see a personality disorder, I can give one or two examples from my patients as well as my associates, at least traits. Now, schizoid is aloof, guys, detached and a bit like a nerd. They're emotionally cold, right? They like to do solitary activities, right? They don't seem to enjoy relationships, little interest in sex. So they're like lonely but aloof. They're okay in themselves, right? They are not toturu randa, I'm so lonely, I have nobody. No, they're not that type. They're okay in their aloof, cold lives, right? Now, schizotypal is, more or less similar. These cluster guys, they're like odd, eccentric speech, right? There are little distortions in their perceptions and thinking pattern, right? They are a little social anxious, schizotypal, right? Don't go and by heart these individual features. We are not that stupid to give you MCQs on like these fine-tuned clinical features, but you guys should have a little overall idea about these type A's, right? Now, antisocial PD is something we usually ask from you guys, because it's important to know these things in your personal lives as well. There are medical students, currently they're doctors. Some girls, they contact me and say, thanks to you, madam, I think I just got away from in a relationship with a typical antisocial PD guy. So I feel, okay, forget the MBBS, at least they have, learned something for their lives. Now, girls, don't take me wrong. Not every guy is a speedy, right? Not every bad guy is a speedy. That guy is just bad, right? So not every guy is a speedy. Not every badass guy is a speedy. And now these guys, they're very callous. They don't give a dash about the other person's feelings, whether they get hurt, they have very transient relationships. They're irresponsible. They don't take care of the partner. They don't feel for the partner's pain and emotional distress, right? They can't follow the society rules. They're very impulsive, they're irritable, aggressive, reckless. This is one of the key features of antisocial PDs. They lack empathy. They lack guilt. They don't learn from their mistakes. They don't repent about their aggressive lives, the behavior. Now, for example, I mean, normal people like you and me, assuming we don't have any personality disorder, if we hit even a dog, we feel ayo ahinsaka sata ayo asarana sata pavam. We feel. But then these buggers, say he hits a guy at a bar, right, liquor bar. Then he would say, the bastard deserved it, dog. I hammered the fellow. And the poor bugger is now in hospital ICU. But other guy doesn't have remorse, right? So initially, they're very charming. And girls, we feel, my goodness, I'm so lucky. I got very charming. They would open the door for you at the car, My goodness, you should just start living with them. You don't have to live with them under one roof. If you start going out with them, say at a bar or at a party, at a dinner table, there's a passing by waiter who looks at the girlfriend a little intently. Other guy would get up and hammer the waiter. They are so into violence. They're very impulsive. They get very reckless, callous, unconcerned about the feelings and the needs of others, right? Antisocial PD. Now, hands up, girls who wants to have a relationship with a ASPD guy. Man, I'm putting my hands way down, thinking that you might say, right? Now, this is our very common borderline personality disorder patients. In ICD-10, somebody tell me what's the term in ICD-10? Come on. Peradeniya. Okay, anybody from Jaffna? Peradeniya, guys, they don't know. Jaffna, show your colors. What's the ICD-10 term for borderline personality disorder, guys? Come on. Ooh, nobody knows. Everybody knows, but I think you all are shy. Give me a chat at least. Come on, guys. Yes? Do you hear me? Do you all hear me? What's ICD term for borderline? Yes, come on. Current group who's doing psychiatry with me, answer. Or else I can give you some time for you to work extra. Come on. Somebody? Yes?
Emotionally unstable personality disorder.
Very good. Well done. Thank you. Very good. Emotionally unstable personality disorder. Very good. Very good. And there's another subcategory as well. But emotionally unstable is good enough for your purposes. So in DSM-5, we talk about borderline personality disorder, right? Now, the hallmark of these people are, they are very unstable in their relationships. They're very impulsive. They have such an mood-wise, feelings-wise, they are very instability, affective instability. So if I am to highlight these many bullet points, they feel so empty, lonely. They feel so empty in themselves. They frantically tries to avoid abandonment. They fear the loved ones in their lives will abandon them. They have very unstable interpersonal relationships. Okay. And idealize, say, for example, now this is more common in females, right? Females, borderline PD is commoner in females. And of course, there are guys who are having borderline personality disorder. Now, these females, they fear, they dread either actual abandonment or perceived abandonment. Borderline, yes. And perceived abandonment is also feared by these people, right? And say, for example, they have very unstable interpersonal relations. When they get into a relationship, right, they intensely get attached to the guy, right? However, say the boyfriend decides to go and watch a ball game with his buddies, then our girl says, whom do you love most, your friends or me, right? You have to decide. You come see me. Don't leave me alone, right? Then the boyfriend gets really stuck in the middle, yeah? Then, of course, he also, after doing everything for the girlfriend, he is craving to go out and watch this football game with the guys. So he goes out. Then our girls gets pissed off. And he says, my boyfriend is the worst guy under the sun, until the boyfriend does everything for her, he's the best guy. It's not she's being ungrateful for or anything, guys. It's the personality, right? She gets frustrated and says, devalue the relationship and everything, right? And identity disturbance, they struggle as to, okay, who am I? I don't know who I am. And they dissociate sometimes. Dissociative features are there. They suddenly they feel as if they are not there in that situation. So depersonalization, dissociative features, and transient psychotic features are also there in borderline. So sometimes students and very junior registrars, they get really confused. Oh my God, this girl is having anger management problems, some psychotic type persecutory ideas, bordering on delusions, and even dissocial. I don't know what to diagnose, kind of, So they feel very empty. I will give you beautiful 2 movies for you to watch. Antisocial, there's a movie called Fear. Fear. Okay, it's an old movie, but it depicts such beautifully what an antisocial PD guy is like. Now, Fatal Attraction is a pretty old movie, right? That also gives a very good idea about borderline PDs, right? So those are the 2 main personality disorders we ask from medical students. Histrionic, they are drama queens, very dramatic, very interesting. Read about it. You may get a little MCQ or 2 here and there, stem of MCQ. Narcissistic is a guy is like, okay, everybody should know who I am. I'm the guy. Everybody should respect me at the hotels, at the dining restaurants. They should respect me. They should have the best table for me. You don't know me. I'm so and so. That kind of a Hollywood, Bollywood, sometimes consultant level, mentality, grandiose, self-important. And girls, it's very important to make sure you have not fallen for a narcissistic guy, because there's a concept called gaslighting. Just read, just for fun, not necessarily for the exam. Gaslighting. That's a beautiful old story around this gaslighting. Now, girls who have already fallen in love with someone, having a relationship, if the bugger is narcissistic, I don't have the heart to say, but be careful, at least just, just read around it and see. Man, I wanna now. If you ask me, I wanna run 5 miles away from a narcissistic PD. But I think as a psychiatrist, I can't run. If they come, I get them to read about their conditions and we work hard. And, they are intelligent people, but they can't help themselves. We all have a little narcissistic traits. However, if you have the traits, people have insight, they know to keep their mouth shut. If you're at disorder level, you can't help yourself. Your personality is doing a lot of harm to you without your control. Avoidant guys are the cluster C people. They're very, this will clash with your diagnosis of social anxiety disorders. Social anxiety, right? Social phobias, right? So just read whether this is a enduring pattern characteristics. Is a bit of a tough game to see whether it's a personality disorder or the social phobia. Usually we give you medical students social phobics as long cases and at the mock keys, yeah. But no, there are personality disorders with these features, right? When you look at it, as very young medical students, we all felt these things, no? Feelings of inadequacies, fear of shame, fear of dislike. But those are normal human characteristics. However, if this cluster persists for a long time, pervasively through every situation, and that's blocking your lives, your functionality, then it's a personality disorder, right? Dependent personality disorder, like Harima Vatya Kane, Bachao, in Hindi, in films, Bachao, you help me, I can't do anything, I can't say boo to a goo, please look after me, dependent, right? I think then narcissistic guy, as a husband for a dependent PD, they will survive a little bit. Yeah. Monkey hito, I'm the poorer, that kind of. So OCD, anancastic personality disorder, and we see a lot of anancastic personality disorders or obsessive compulsive personality disorder. Now, medical students, please, there's a very important point I want to make here. Do not confuse obsessive compulsive personality disorder with obsessive compulsive disorder. OCD is an anxiety disorder. Obsessive compulsive personality disorder is a personality disorder, nothing to do with OCD. So at your level, use the term anancastic personality disorder. Anancastic personality disorder guys are very rigid, non-flexible. They are very conscious. They're not flexible. They're not fun to live with. They're not suspicious, but they want everything their way. They're so rigid. Imagine not taking a turn in a bend, you will get into the ditch definitely. So having an anancastic personality disorder husband will drive a wife mad. Everything you need, everything there, right? Some of us professionals also have these anancastic traits. However, it's not fun to live with an anancastic PD, because if you're pregnant, if the wife is pregnant, the anancastic PD decides what to eat. So the pregnant woman has to eat, even for her doladuka, what the anancastic husband says. Because he's the boss, he runs. It's not narcissism, but he has a way of doing things. So he wants everybody to follow his rules and regulations. Anancast. Okay? So what do? Man, it's not easy to treat personality disorders. You need expertise. You need, there are a lot of ways to treat. Pharmacotherapy has a little role. Psychotherapy is the mainstay. if they are suffering from depression, now these anancastic guys, just because the world doesn't follow their own rules, they tend to get more depressed. So depression is a common comorbidity of anancastic PDs, and so is the depressive episodes, like transient depressive episodes are there in borderlines as well. Okay, some of the borderlines, they have deliberate self-harm. I did not go into that bit, but borderline PDs, a very common thing is they are hurting themselves, superficial cuts and all those things. I invite you to go through the MCQs given in the past. I know you guys, every faculty has MCQ, right? Although we don't encourage you to break them, just go online and see what borderline personality disorder is like. There are very nice YouTube videos by professionals. Don't just go and watch anything. If I find some good videos, I will Moodle it for para students, and you can share the links with your peers in other faculties, no issue. Right? So they hurt themselves, okay? Borderlines. Right, so histrionic, the drama queens, narcissists, the big shots who avoidant, anxious, dependent people, anancastic, Sleeping with the Enemy movie. There's a character that has some anancastic personality features, disorder features, okay? And I have to tell you guys, just because one person is having one personality disorder, that doesn't mean he or she can't have another personality disorder. It is very common to find mixture of personality disorders. That could be a very nice MCQ point, isn't it? Right. I'll keep that in mind for the next common MCQ. Right. By the way, we have finished your common MCQ papers, huh? Right. Psychotherapy. I'm sure you all are very bright students. You work very hard. I'm sure you will get through most of you. So don't worry too much. So borderline personality disorder, very typical. The treatment is dialectical behavior therapy. It's a variant of cognitive behavior therapy. Its main goals are to teach people how to live in the moment. Mindfulness aspect is there. Live in the moment, develop healthy ways to cope with stress, regulate their emotions, control your emotions, regulate, manage your emotions, not control, but manage your emotions, and improve the relationships with others, okay? And pharmacotherapy is having a little role. We don't want you guys, we don't expect medicos to know the treatments of personality disorders, because we psychiatrists are also having our head against the wall sometimes, hitting our head against the wall sometimes. It's a tough game. Prognosis is variable. However, some PDs, as I told you, becomes a bit milder when they grow older, right? It's very important the families know about the personality disorder, then they can adjust or they can leave if they can't live. So these are my references. I mainly went through the DSM-5 when I prepared this, but your term is ICD-10, so I got those little classifications, like the details of this borderline personality disorders. No. Details of the personality disorders from ICD-10. Thank you very much for being there and coming. I have to leave this meeting because this forum has to be given to the Journal Club Peradeniya. Just before leaving, how are you all? Did you hear me clearly, Jaffna students and our students? If you know not, if anybody has any signal problems, connection problems, data problems, of course, this link will be sent to you for your personal use. So you can share it with your people. All right. Are we good? One chat. Okay. No worries. Okay. Rasika, you're welcome. Right. Okay. Bye, people. I have to leave the forum in order to give the platform to the Journal Club Peradeniya. And if anybody has any problems, you can email me, pabasari@gmail.com. No, Mahaprana, Pabasari, Ginige@gmail.com, right? All right. Okay, welcome. Welcome, Jaffna. Welcome. Right, okay. It's lovely to have you guys connected. Lovely. Right.